So I thank you for letting me be part of this instruction course. And I'll be talking about central serous chorioretinopathy. Imaging may suggest otherwise. So first, let us look at what is central serous chorioretinopathy. Basically, it is choroidal congestion and hyperpermeability, which results in focal RP defects and a serous pigment epithelial detachment and or a neurosensory detachment. So it is more common in males, but this gender predilection decreases with age. Older patients are more likely to have a bilateral disease. Now, CSC presents with certain typical features on imaging, which include gravitational tracts on fundus autofluorescence. Apart from the PED and NSD, subretinal fibrin, elongated photoreceptor outer segments, and in chronic cases, outer retinal atrophy and cystoid changes on OCT. FFA can help to prick up the leak at the level of the RP, and ICGA confirms the choroidal venous dilatation, vascular congestion, filling delay, and hyperpermeability, which underlies the basis of this disorder. So let's look at a typical case. This was a 50-year-old male. Right eye was asymptomatic, 6/6, and showed this serous PED, which we can see on FAF, FFA, and ICG. And the OCT also confirms this. This was the other eye of the patient, which was a chronic CSC picture. Here you can see the autofluorescence changes, the pinpoint leak on the FFA, and the choroidal vascular dilatation and hyperpermeability. This is the OCT scan, again showing a thicker choroid and the elongated photoreceptor outer segments pointing to the chronicity. So as per the current nomenclature, CSC has been included in the pachychoroid disease spectrum, which is characterized by reduced fundus tessellations, a thick choroid, which may be focal or diffuse. Here you have a loss of the small and medium choroidal vessels and dilatation of the large choroidal vessels, which are called pachy vessels, which is highly apparent when you compare this to a normal OCT scan. Now let's look at some cases which appeared to be CSC, but then we realized it was something else. This was a middle-aged female who complained of suboptimal visual gain after cataract surgery. Visual acuity was 6/12. There was a PCIL in C2, no anterior segment complications. This is the fundus autofluorescence. You can see stippled hyper and hypoautofluorescent areas, and this is the OCT showing a NSD along with some dilated outer choroidal vessels. FFA, again, stippled hyperfluorescence, and look at the OCT angiography. There was a small tuft of new vessels present here along with the high flow, which made us revise the diagnosis to a pachychoroid neovasculopathy. And in fact, if you go back and look at the scan, you will see a subtle double layer sign here overlying this pachy vessel. Now, this disease is again part of the pachychoroid spectrum and is nothing but a type 1 or sub-RP neovascularization over an area of increased choroidal thickness and dilated vessels. As opposed to ARMD, these patients are younger, they do not have drusen, and of course, no myopia. So the clinical significance of this disorder is that it could be a form truste of PCV, and the management is different from CSC in that you need anti-VEGF treatment. Another case which presented with the neurosensory detachment on OCT, this was a middle-aged female with decreased vision to 6/24. But look at the clinical picture. In addition, you have disc hyperemia, yellowish lesions over the macula with subretinal fluid, and FFA showed the typical early hypo and late hyperfluorescent pattern. The disc was also hot. So this suggests this is an inflammatory disorder and not CSC. Further looking at the OCT, you will see that there is choroidal elevation and thickening, and these multiple septate neurosensory detachments, which are typical of VKH syndrome. Now, again, it's important to recognize because the management is different. These septate NSD are in fact bacillary layer detachment, which is a split in the inner segments of the photoreceptor layer between the myoid and the ellipsoid zone. And it has been increasingly realized that this may be a surrogate for underlying choriocapillaris ischemia. Now, you can see that with appropriate immunosuppressant therapy, there is a good anatomical and functional outcome. Now, this is the third case, a young male with decreased vision in the right eye to 6/36. And again, you see a neurosensory detachment. You may be tempted to make the diagnosis of CSC. But what about this elevation? Look at the fundus picture. And this was actually a granuloma. This can be related to tuberculosis or to sarcoidosis. And here we clinch the diagnosis by the other eye, which also had pigmentary changes suggestive of ocular TB. The Montu was raised and the HRCT showed lymphadenopathy. He was started on steroids along with ATT, leading to a resolution of the granuloma as well as the neurosensory detachment. Another patient with decreased vision in the left eye, 6/12, headache. And here again, on the OCT, you see a CSC-like picture. There's a neurosensory detachment. What is different on OCT? On FFA, you see no leak, just pinpoint hyperfluorescent spots, a bit of hyperfluorescence at the disc. So what guides you here is the headache. A CSC should not be accompanied by a headache. And the other thing is, if you look at all the OCT scans, you see these undulations in the RP chorocapillaris complex. So this should prompt you to order a B scan, though it's not very clear in this scan, but this was a case of posterior scleritis. It's important to recognize because up to 50% cases are associated with the systemic disorder such as rheumatoid arthritis, granulomatosis, or polyarthritis nodosa, especially in a middle-aged female. And for the management, you need oral steroids or immunosuppressants, much on the contrary to a regular CSC. Now let's look at this case. This was another elderly middle-aged female with decreased vision in her left eye. She was a myope and the vision was 6/18. This is the vertical scan on the OCT, again showing you a neurosensory detachment and some photoreceptor outer segments elongated over here. The FFA and ICG just show stippled hyperfluorescence and hypercynescence respectively. Now what next? What should you do in this case? So always remember that you should check out all the scans of the OCT, not just the vertical, but also the horizontal scan. So on the vertical, what looks like a CSC, in fact, is a dome-shaped macula with subretinal fluid, which you can only pick up if you do a horizontal scan. So OCT angio, which showed absence of any neovascularization. So what is a dome-shaped macula? It's an inward deviation of the macula with respect to the chorioretinal concavity, usually seen in myope, as in this case, though it can also be seen in emmetropes. Younger age and longer axial length are the risk factors. Now, this is important. The dome can be horizontal, vertical, or round. So if it is horizontal, you need a vertical scan to diagnose, which is the most common. If it is vertical, you need a horizontal scan to diagnose. And if it is a round, it can be picked up on both the scans. Now, the scan should be of a sufficient length as well. Here you see it's missed on a horizontal scan. Can I request the rest to please mute them? Yes. Here it's missed on a vertical scan. And here you see if it is not of a sufficient length, then it will be missed on both the horizontal and vertical scan. So the take-home message is you must do at least one horizontal and one vertical OCT of sufficient length, especially in a myope, to detect a dome-shaped macula. Now, the natural history encompasses an increase in the height of the bulge with time as a result of the deepening of the surrounding cephaloma. This is not accompanied by a hypermetropic shift. Now, SRF without CNV is the most common and resolves over time in over half the patients, though it can leave RP atrophy. The management is same as CSC, but the prognosis is much more varied. So again, to repeat, what looks like a CSC flat irregular PDs on a vertical scan turns out to be a dome-shaped macula on the horizontal scan. Another condition that should be kept in mind is the tilted disc syndrome, which presents very much with a dome. But the differences are that there will be. Can the host please ask the remaining to mute themselves?
I use this thing. It has the clamp at the bottom. And I can put my phone up here.
Mr. Vinod, can you please? Okay, thank you. So a differential in this case is the tilted disc syndrome, where you see more tessellations in the inferior fundus compared to the superior. You'll also see a tilted disc with the intranasal crescent or a conus and situs inversus of the retinal vessels. So the cephaloma is only inferior in this case. The lesions are similar to a dome-shaped macula, as you see in this case. But the shape of the dome is more circular in dome-shaped macula, whereas it is more eccentric in a tilted disc syndrome. Another condition which should be kept in mind is a ridge-shaped macula seen in younger patients with high myopia, where the elevation is only seen in the vertical scan. Now let's go to our next case, which clinically presented with a NSD, where you again may be tempted to make a diagnosis of a CSC. But look at the infrared image of this 60-year-old male with decreased vision in his left eye. Here at the top, you see some hyperreflectance on the near infrared reflectance image. This should prompt you to go ahead with a FFA and or a ICG. And here you see a well-circumscribed lesion in the superior part of the fundus, which had very early filling on ICG. Now, this is a classic choroidal hemangioma. And again, it presents with the neurosensory detachment, but there will be an elevation on the OCT as well. Here you see some RP deposits, which account for this hyperreflectance on NIRA. This patient did well after PDT. So at this time, I'd also like to put in a word about paraprotein maculopathy. So paraproteinemia is seen in multiple myeloma, immunocytoma, and Waldenstone macroglobulinemia. Though it usually presents with venous testis retinopathy, rarely you can have only a serous macular detachment mimicking a CSC. It may be unilateral. So the key point here is the absence of angiographic leakage. And you must remember that the height of the SRF is directly proportional to the IgM level in the blood. So these are some of the pictures that you can see where you get these high NSDs and some hyper reflective deposits on fundus imaging. Now, this is important because it can be a clue to a systemic malignancy, and in conjunction with the hemato-oncologist, the patient definitely needs plasmapheresis and rituximab or chemotherapy. So this is something which should not be missed. Now, this is my second last case, a young female with decreased vision in her right eye, visual acuity of 624. Here you see NSD where you can see all the borders on EST. So what is this? Look at the fundus picture. You see some RP changes, but look carefully at the disc. There is a disc pit, and this is a case of a disc pit associated maculopathy. Now, here again is a clinical indicator. If you see the horizontal scan, the vertical scan is showing only the NSD, but the horizontal scan is showing some vitropapillary traction at the edge of the disc and some inner retinal schisis in this area as well. So we have seen a considerable number of cases of disc pit presenting only with subretinal fluid, and this was a case of double disc pit.
Doctor, so sorry to interrupt, but you need to sum up within 1 minute.
Yeah, sure. So this is in contrast to Linkoff's theory, who said there should be a schisis followed by an outer retinal hole for this SRF to accumulate. These cases show that fluid from the pit can directly go to the subretinal space as well. Now, this is the last case. What would you do next when you see this OCT picture? You think of a CSC and maybe do FFA. Look at the fundus. Here you see some retinal striae, but always remember to do a distant direct ophthalmoscopy whenever you have an NSD on an OCT whose margin you cannot see. This is actually a case of a very shallow superior retinal detachment with the dialysis in a young male. Another pointer on OCT is these inner retinal folds that you will see, which again point that this is in fact a shallow retinal detachment, which you should not miss. So to conclude, there are a host of systemic disorders associated with the neurosensory detachment. You can have lesions similar to CSC, which can be neovascularization, inflammation, tumors or malignancy, a surgical condition such as an RD, or other rare ocular disorders such as a dome-shaped macula or a optic disc pit. It's important to recognize these because the management differs and the prognosis also differs. So a host of ocular and systemic disorders with varying management and prognosis can present with the neurosensory detachment on OCT. Subtle signs on OCT and diligent interpretation of all the scans can point towards an alternate condition other than your knee-jerk reflex, which would be a CSC. A careful clinical history examination in conjunction with appropriate imaging modalities can help clinch the correct diagnosis and institute the appropriate management on time. Thank you for your patient hearing.